Great. Well, I feel especially honored to have all of these opportunities to share great stories and great information with this audience. So thank you, Sam, and to the organizers for allowing us the opportunity. And I'm going to go ahead and share my screen if you don't mind. Okay, and I assume everybody is seeing it.
Yep, we can see it.
Perfect. So let me welcome everybody to this session. This is going to be a bit different. This session is about leveraging geospatial data for COVID-19 response. And as you know, I serve as the Chief Medical Officer at Esri, but I have to tell you, I'm really excited about this panel and this discussion. And honestly, I'm pretty honored to be joined by an esteemed panel of experts. And so I'm going to introduce them, and then I'll tell you about the agenda for today. First, we have Juan Pimento, who is a senior advisor for special projects and also importantly, a geospatial matters engineer from Panama's National Authority for Government Innovation. Ms. Jisoo Kim is a GIS analyst joining us from PAHO, the Pan American Health Organization, and Dr. Thiago Rocha is a researcher from Duke University who has been focused on the exciting area of GeoAI-based microplanning. Sometimes you got to slow down for these titles and areas, so I will do that. So let me share with you the agenda for this session. Now, following my brief introduction, we're going to hear presentations from our three panelists. And we're going to begin with our colleague from Panama, and then we'll be followed by Ms. Kim from PAHO, and then Dr. Rocha. So you're going to get that understanding of their work and what they've been doing to leverage GIS for the pandemic. Then we're going to have all of that background so we can begin our discussion. And as moderator, I get the privilege of asking a few questions first that I have for our experts, and then we're going to open it up to your questions. So my recommendation, as always, is get those questions entered into the Q&A section as soon as you think of them. And then I'll be able to organize them and ask the presenters on your behalf. And so let me just say a few words of introduction. I know that over the past 12 to 16 months, depending on where you're from and when the pandemic hit your country, that geospatial data has been put to good use for COVID-19 response. And there are patterns of GIS use that many have adopted. Some of you were in the last session, so you know some of those, but I would say this idea of situational awareness map-based dashboards, honestly, that's the first and most prevalent pattern we've seen, with hundreds, maybe thousands of those kinds of dashboards. And then there are use cases, of course, that are more unique, that are customized to a particular locale. Like I remember early in the pandemic, there was a county in Georgia, Cobb County, and they created this community app so that people could share information on which grocery stores had staples like milk and eggs, and toilet paper, of course, was a big one. And then people would know where to go, where there was current inventory. Then there was another one, I think we talked about it if you were in the last session, this local survey of attitudes about COVID vaccines from people who are experiencing homelessness. I mean, that was a pretty unique situation, and so they developed an app just for that. Now, the discussion today is really going to shine a light on what I find amazing work that these organizations have performed using GIS. And you're going to see tremendous planning and vision, and then execution of workflows that have significantly advanced the public health mission around COVID-19 response. So without further ado, I'm going to ask Mr. Juan Pimento if you are ready to tell your story.
Morning. It's a pleasure to be here with you. How are you, Esther?
I'm doing great.
Great, great. Good morning to everyone that's attending this conference. It's an honor to be here. On behalf of Dr. Felix Correa, I have to apologize. He had an urgency and he will not be joining us. So I'm going to be having the sole honor of talking to you about what we have been doing with COVID. So back on March, March 9, 2020, what we knew that was going to happened. We had our first COVID case here in Panama. It was a patient that arrived from Europe, from Spain. And from that day on, we started implementing alongside with the Ministry of Health and the Unified Health System, a series of, let's say, digital transformation express systems that allowed us to quickly reach the population as they were feeling ill and perform this COVID-19 tests, of course, by the aid of using geospatial information systems, such as what we accomplished with Esri. Now, how we did it? What we did is that we consolidated a digital ecosystem with georeference data in its heart in order to integrate a diverse set of other systems. We knew that we had to reach the population in a really effective manner. So we developed a couple of bots, of chat bots that allowed the population to WhatsApp or to interact with us through Facebook or Twitter and telling us like, hey, I'm feeling ill. This is how I'm feeling right now. And of course, this is where I'm living. So they were able to give us their location and all their personal data. And after that, we integrated this chatbot system into a medical call center. So I'm sorry, a medical contact center in which we had a series of doctors. We called them the Rosa Consultorio Virtual, which is Rosa is the name of the chatbot that we created. And what they did was that they used your reference tool, which is called Survey123 from Esri, and they gathered all the different information from this COVID-19 suspected patient. That was the state that was assigned. And then we used, and I'm going to be sharing a couple of screens so that you can get an idea of how we did this. Just let me know if you're able to see them. Let's just share the whole screen. So the way that we did this was by monitoring, okay. So the way that we did this was by monitoring nationwide, by assigning all our quick response teams. A quick response team is a team that's composed by a doctor, a nurse that performs the swab, and an officer from the law just to go and reach different communities nationwide. And what we did was that all this information that was gathered by survey, we started just deploying it through a series of tablets that the quick response teams had, and they knew exactly where they were going. So all of a sudden we had very quickly an operation that was nationwide that allowed us not just to send our quick response teams to each one of the sites where we had people that were feeling ill, but we could also do we also perform what you're looking at right here, which are indicators that gave us all the insights that we needed in order to understand if we were getting to the people exactly at the time that we needed to, and in which one of the health regions we were really getting there and getting all the population, all the different tests. What you're looking at is basically a summary of the operations that were performed at a time given. So after this, our quick response teams validated all the different patient data, also with another different survey form, and then this was given by means of web services integrations to the national laboratory systems, which is where we at the end process the data, and then we perform all the different integrations with the health system. And by deploying field georeference applications, integrations via Python notebooks and dashboards such as this one that I'm available to share at this time, we achieved operational efficiency, situational awareness, data analytics, and of course, a digital express transformation that otherwise would have taken us really long time. So we underwent through this digital transformation effort in a little bit under 45 days. In a national scale, we started first at the city capital in Panama City, Panama, and then we started upscaling this to different health regions. And what this allowed us was afterwards, as the government changed its COVID-19 strategy into doing a more aggressive sort of tracing, is that we created the regional tracing, COVID-19 tracing centers. And we developed another set of dashboards and insights that were also used in a local level to basically trace what was going on with the local COVID-19 cases. So this is a really interesting, let's say, way of using georeference data in order to trace a pandemic such as the one that we're living right now. Now, the second part of the digital express transformation, the health system that we performed by means of using georeference data, such as what we have been doing with Esri, with our ArcGIS and the other platforms, is what we called the massive vaccination operation. Now, this is the part two of what we're presenting right now. It's back in September, we knew that we were going to be receiving the first set of Pfizer vaccines at the beginning of 2021. So we started developing also an ecosystem that allowed us to perform planning and monitoring of the nationwide vaccination efforts with the use of data analytics. And we did this with four main pillars. The first pillar being the population prioritization, in which we used a lot of big data tools because we had to classify the priority of the population into who was going to get the vaccine shot first, the vaccination first. But we needed to do this in a georeferenced way so that we can better have a higher level of efficiency as we were doing the vaccination efforts. We also needed to integrate something which was the vaccine cold chain, all of this cold chain logistics that you are having when you're dealing with a vaccine such as Pfizer, that at the beginning had to be kept below 70 degrees Celsius in order for the vaccine to be useful. And then we needed to properly register each COVID-19 vaccination event so that we could be able to trace the vaccination event into a single person with a specific vaccine, COVID-19 vaccine batch, and also the place where this vaccine was being administered. So what we did was that we implemented a ubiquitous technology ecosystem by which we used portable devices such as this one that I'm holding, that allows us to read the Panama's national ID in a really quick way and to gather georeference information in the field as we are performing all the different vaccination events nationwide. We also implemented in this system a system that allowed us to integrate the different logistic data as all the different dispatches and registers of the cold vaccine chain as it was going. I'm going to share the screen again just to give you a glimpse of what it is that I'm trying to explain right now. So this is one of the dashboards where it is, this one. This is more or less the summary of the logistics operations that we're doing. What we're doing is that we are gathering in real time different dispatches as they're happening of the different COVID-19 vaccines as they're dispatched from the national center, which is located here in Panama City, Panama, to each one of the different health regions, and each dot here represents, of course, a vaccination center. So we have a registry of different dispatches that are happening right now. We know where they're being dispatched from, who is dispatching them, and where they're being carried at any time, at any given time. And we are also monitoring exactly how many doses, how many vaccine shots we are giving in real time. And what this gives us is that by building an integrated ecosystem, and using powerful data analytic tools such as the ones that Esri gives us, we're able to trace, as I mentioned earlier, each person to a specific vaccination event with its vaccination center. And this allows us to see how the demand is being consumed in real time. So this is, for instance, what we're doing today. This is our current vaccination effort in Panama. We have a heat map, and we're able to see how many vaccines shots are being administered at this time. This, of course, helps us to understand how many vaccine shots have been dispatched into a specific vaccination center. And by allowing to see how this demand is being consumed, we can also foresee if we need to send more vaccines into a vaccination center that we know that's going to be receiving much more people. So what we achieved likewise is that by deploying field reference applications and integrations, and believe me, a lot more dashboards that, because of they have several data I cannot show, we're able to get in-depth real-time data analytics, situational awareness, and operational efficiency. And by the way, this dashboard here is public. It's called the Vaccinometer. So the population can see how many shots are being administered based on sex, based on the health regions, on the different provinces, the different districts. And it's open for the public. It's a transparent process. And we're really happy and thrilled to use this sort of tools that allows us also to achieve a high level of efficiency. So that's more or less a big summary of what has been a really heavy year of express digital transformation. I believe that we have all suffered, and yeah, we're looking forward to a bright future. Thank you.
I bet. Thank you so much, Juan. It's amazing, and I can't wait to get to the discussion part. But before we do, I want to introduce next Ms. Jisoo Kim from PAHO.
Hi, everybody. My name is Jisoo Kim, and I'm here representing a wonderful team within the Pan American Health Organization, which I'll refer to as PAHO. PAHO is one of 6 regional offices of the World Health Organization, and we provide technical support and leadership to the member states in the Americas, which spans countries in the Western Hemisphere as north as Canada and as south as Chile. The team that I'm here to represent is the COVID-19 mapping team. And our team within the Health Emergencies Department, we try to understand spatial and spatiotemporal epidemiology of epidemic-prone diseases like yellow fever, cholera, and right now, COVID-19. I'm thankful for this forum to share our experience in the endeavor of surveillance, because while preparing for this presentation, it's given us a chance to reflect on the past year, on our surveillance system, the data collection, and for us to, hopefully this is an opportunity for us to learn what went right and address what went wrong. So let's rewind back to the first months of the pandemic. In March and April, intense COVID-19 outbreaks were occurring in countries in Asia and Europe. And while in the region of the Americas, the first sporadic cases were being reported in some countries. So during this time, we stood up our incident management system with the plan to save lives and slow the spread of the virus. By June, July, and August, the highest number of cases were being reported in the region of the Americas. 50% of cases at this time globally were from this region, when we represented only 13% of the world's population. So PAHO has to plan massive operations to support countries with this goal in mind, to save lives and slow the spread. To guide all of these decisions, we have to have good surveillance. And we believe that this is the key to generating evidence for action. We need the data to understand the situation, and I'll talk a little bit about how the surveillance aspect of our work and what kind of data we collect, how we collect it, and how we use them. So how do we do this? How do we generate evidence for action? Our team seeks to do this by integrating geospatial data and analytics to support comprehensive and dynamic response to COVID-19. We promote international coordination and situational awareness by sharing this information. And we provide near real-time information to countries to strengthen their surveillance systems. So the crucial aspect that our team provides to this end is surveillance data, reliable and timely surveillance data. Our team has three main surveillance data that we collect, manage, and analyze. There's the country-level daily reporting of the 54 countries and territories. There's subnational level daily reporting with cases and deaths for 791 states, departments, and provinces for the 54 countries and territories in our region. And the third, but not least, is the case report form, which has a record of around 40 million records right now in the database that includes case-based variables such as age, sex, outcome, and comorbidities. But from here on out, we really want to focus on the first administrative level data collection. So from the beginning of the outbreak, we decided that we needed to collect subnational data. And in the beginning, when there were only a few cases in a few departments, it seemed like a good idea. And it was. It really helped us track the introduction and spread of COVID-19 cases in the region. I apologize for the helicopter noises. But what was a good idea at the time in the beginning became very burdensome because, as I mentioned, there were 791 states, departments, and provinces in this region. So we thought, we spend a lot of time on this task. We should probably write a program automating it. And in theory, we'll work very hard to automate the data collection, and then we'll have all this time, free time after to do other tasks. This is brave thinking coming from a group of epidemiologists and not computer scientists. So in reality, naturally, this is actually what ended up happening. So we're somewhere in the middle of debugging and ongoing development right now. We learned basic Python, Excel macros, Google Sheets to set up automated data collection. And we're very aware that our solution that we have is not the most efficient example of finesse, but it ended up helping us. Of course, not every country has sources that we can use. Sometimes there's an image on a Twitter or Facebook, or the codes that we wrote break, or there's change in the name of a variable, or the API source that we're using is broken. We have to enter things manually. And that's really the thing about global surveillance. The ministries of health of our countries report the data, and we try to work with the ministries of health to build adequate and robust surveillance systems that we later use to understand the disease dynamics at a more global level. But as you can see, the data that is available is not a one-size-fits-all. This trend has become even more pronounced while working during the pandemic. Ministries of Health wants to publish detailed and almost real-time daily data. And this makes sense during this pandemic because it's an outbreak of a respiratory virus and it moves very fast. So we're working on mitigating the outbreak, and we need a bit more granular subnational data. So to look at this information across national borders, we don't just collect subnational data that's reported. We have to scrape it, we manually plug it in, we set up automated processes, and as more technology becomes accessible to us and our countries, number of solutions tailored to individual countries has also increased. So at the end, what do we do with all this data that we collected? the data that we collected allow us to identify problematic areas across national borders. It allows us to see hotspots with more intense transmission that's hiding in maybe national data with more moderate transmission levels. And it allows us to support countries that don't have data publicly available online by publishing our data. And it allows us to improve the information system or the data flow from country surveillance to ours. And in this regard, I want to tell you about one particular place in the Americas that exemplifies how we use this data to support PAHO actions. This is what the incidence rate map at subnational level looked like at the end of July of 2020. Do you notice anything about this map? The incidence rate of COVID-19 were high, spanning national borders in the Amazon region across Brazil, Colombia, Peru, Venezuela, French Guyana, Guyana, and Suriname. Amazonia is a geographic area delimited by Amazon River basin that covers 9 countries. COVID-19 cases and rates in this region are some of the highest in the American continent. Coronavirus took root in the Amazon, traversing between isolated settlements along rivers and established widespread community transmission out. It's also a very special place where hundreds of ethnic groups, including indigenous peoples whose traditional and cultural beliefs existed for centuries. And there are many vulnerable populations living in isolated communities here as well, lacking healthcare services, doctors, lab tests, and treatments. And this data that we collected was critical in helping us identify the problem. And once we realized, we tried to identify specific risk factors and vulnerabilities among the people who live here in the context of the COVID-19 pandemic. And we also used our information to provide human resources, supplies, medical devices, including lab tests and treatments. And now we are kind of looking at the same place where this started. In January of 2021, states in North Amazon region of Brazil experienced a surge of COVID-19 cases with a large increase in deaths and hospitalizations. Brazil worked tirelessly to mitigate its impacts of the lack of ICU and hospital beds, health professionals, healthcare supplies, including oxygen. And now we're working with the Emergency Operations Center at PAHO, and they're the ones who coordinate and control the response activities to develop this webpage. We're tracking the gaps identified by our people on the field in Brazil, and we share this information on the website that we built using the Esri Hub that we heard about this morning to build a virtual situation room. So this allows the people in Brazil, Colombia, Peru, and Venezuela to understand what the situation is like. We're also tracking COVID-19 cases to identify highly affected areas, and this information is displayed here to give a comprehensive overview of the situation. So this is sort of where our outbreak took us to now. As you can see, the last panel here, the last 3 months, South America, particularly Brazil, continued to have high incidence rates. You can also see that the worst of the outbreak isn't over. It's actually ongoing right now. And we're going to continue to monitor the progress of the outbreak at the global level, looking at the subnational data to identify affected areas and support country surveillance. And as we learn through this pandemic, the use of new technologies that everyone is using, working with ministries of health and their particular surveillance systems, will adapt at the regional level to be better prepared for future outbreaks and epidemics, even if it's not at the pandemic scale. And this is the wonderful team that I work with and who helped me prepare this presentation. And I want to take the opportunity to thank everyone for listening today.
Thank you so much, Jisoo. Those maps practically take my breath away. They're so striking and really paint a picture of the work that you've been doing and what you've been trying to catch up with. So thank you for that presentation. And again, my questions are racking up. But I still invite the audience to add their questions. I promise I'll ask them. But now I'd like to turn to Dr. Thiago Rocha from Duke University to share like what seems to me like the future, but you're doing it now, right? GeoAI. So tell us your story.
Thanks, Darcy. Can you hear me?
Yes, I can hear you fine. Okay.
So first of all, I'd like to say thank you for the opportunity to be here today, sharing a little bit of our experience in how to use ArcGIS features and geospatial artificial intelligence to support the development of micro-planning dedicated to support health campaigns. So, give me a second. Okay, so health campaigns usually to be the main drive of health systems trying to achieve a disease control. And COVID-19 is giving us an example of how the development of health campaigns could be challenging. So to overcome the challenges necessary to address and to design an effective health campaign, it is important to develop new strategies and usually to verify, usually to be sure that the initial objectives of one health campaign are usually detached from the initial goals defined. So when you design one strategy to address or to control one specific disease, very often you are faced with challenges like the lack of information of where population are, or how to estimate a precise number of people to be covered by the actions. And this population estimate is the main information, is the one essential information necessary to conduct every activity comprised within a health campaign. So if you are not capable to identify where people are and how many they are, it is impossible to design the necessary amount of resources to cover this population. And despite the fact that we are facing challenges in terms of health campaign during the last decades, there are few innovations dedicated to address such type of issues. And that is exactly the point that we aim to address with development of the toolbox that I'm going to present to you today. So the solution that we developed uses geospatial artificial intelligence to support development of automated microplanning aiming to support health campaigns. And to do this, we are using satellite imagery, secondary data, health facility location, and the core of ArcGIS to support very sophisticated analysis to estimate the amount of people to be covered in each location, considering one health campaign. The details, the methodological details regarding the development of these two are available in this link right at the bottom of the page. And the publication of the manuscript is under review. So we are planning to release this tool for the community upon the publication of the manuscript. But if you are interested in, you can check this information right here to get all the data sources and the methodological details associated to the development of this tool. So here we have a small region in Nigeria. And as you can see in this little dark area, we have the highest number of people located within its borders. And comparing this information, all these pictures are from the same site. So comparing this information from the Landsat, that is basically satellite imagery collected, you can see that the population is not equally distributed within this whole area. We just have two small settlements comprising the distribution of the population. And to be capable to estimate that you have the population within this small area and not equally distributed in this larger area, it is very important to design strategies for vaccination, for drug distribution, and any other topics that may be associated to a health campaign. And for COVID-19, for example, it is very important to identify where people are, and we have challenges in terms of this because census information used to be outdated. There is some countries in Africa and even right now in Brazil, for example, that the last census was performed 15 years ago. So we don't have a precise estimate of where people are and how many they are. And using this satellite approach, we can go to the satellite images, land cover information, density maps, and census data using artificial intelligence to estimate how much people are located in each settlement covered by artificial buildings or by buildings footprints. So it is possible to estimate, considering 15 days ago, how much people are located in each site, and use this information to support the development of health campaigns. And this is only possible by using artificial intelligence that will analyze all these different types of information and create estimates, precise estimates of the current distribution of the population. After doing this, so we can get this up-to-date information regarding the population, we combined the information regarding the distribution of health facilities. We have some initiatives dedicated to this, like the Health Sites IO. They are sharing information with the GIS community of where each health facility is located. And as you can see in this right side of the page, we gathered this information for the entire America, but this information is available for the entire world, so you can use this as a basis to estimate and to create custom-made catchment areas. With this possibility to gather precise information of how much people are in each site, as well as combining this data with the geolocation of health facility, we developed a toolbox that is capable to create these custom-made catchment areas. This toolbox will be released upon the publication of the manuscript that I mentioned to you, and uses ArcGIS and the network analysis. So with no need of code, you can just input the facilities where they are located, one ID, the network of transportation that can be obtained with OpenStreetMaps, define one output further, and which data sources of which dosimetric population estimate that came from the satellite image do you like to use. And this toolbox will create this custom-made catchment areas for each facility following the parameters defined by the user. So you can define an automobile time or automobile distance, and this feature will analyze each facility and create one specific area like the image that I am presenting to you right now. So each blue dot represents one health facility, and the green area represents the catchment area created comprising 1,000 meters of distance, walking distance. And the red areas represents one catchment area of 2,000 meters of distance, and the red areas 3,000 meters. So you can have this information for each health facility anywhere in the world and overlap this information with the satellite estimate of population. You can identify how much people are covered by each catchment area created. And besides that, is it possible, for example, to identify in these red circles areas where in the satellite presented and identify groups of people that are not covered by health facilities? So other people within these red circles will face some access barriers to get coverage of primary healthcare services, for example. And when you are trying to design a microplan, having this information is essential, because you will be able to design different approaches to reach these people in areas facing access barriers. And the main outcome of the analysis is a spreadsheet, so anyone can use this information. You can integrate this information into dashboards where you have the ID of each health facility and the amount of people in each catchment area. So you can get the amount of people that needs to be covered using up-to-date information gathered from the satellite image processing, and estimate the amount of resources necessary to cover and to vaccinate these people. So you can get a precise estimation of the amount of human resources that we're gonna be needed, vaccine vials, how much time will be necessary, and you can also identify areas facing a lack of access that will need a different approach in terms of health campaign and vaccination efforts. And for this example, we did this pilot testing in one state of Brazil, and we could identify that we have nearly 40,000 people within the custom-made catchment areas, and we have 1.2 million people outside these areas that will face some challenges in terms of access regarding vaccination campaigns, for example. The difference now is that we are aware in how much people are in this situation and where they are, so you can use this information to support activities regarding the micro-planning for health campaigns. We did this analysis for every country in the Americas, so you can have the same estimates, for example, for Mexico, and for any other countries, Peru. So you can have the health facilities, the custom-made catchment areas, and the amount of population linked to each catchment area. So you can find the result of this analysis in this ArcGIS Online dashboard, where you can access and get the results for the same for every country to examine this information in detail if you are interested in. So that's the idea. That's our contact information. Thanks for the opportunity to be here today, sharing this experience, ST.
Thanks, Thiago. Wow, it's very impressive work. And now I'll ask all of our panelists to turn on your cameras so we can start the discussion. Now that everybody's got some background on the great work that you all have been doing, I guess, you know, my tendency is to want to start off with a question for everybody, you know, just in a minute or so. What was the hardest thing, the thing that gave you the most headaches in the work that you were trying to do? So actually, let me start with you, Jisoo. What was the hardest thing?
I talked about it a little bit, but I think for our group, the hardest thing was really working with a lot of coding and that we really didn't have experience with. I mean, a lot of us are epidemiologists, we know statistics and statistical packages, but really to work with the data and learning how to collect all of these in a uniform way was quite difficult for us. But at the end, the solution that we have is probably not beautiful in any regard, but it works for us, and we're continuing to improve it.
That's cool. Well, I think what works definitely trumps what's beautiful. Thiago, how about you? What was the hardest thing?
The main challenge for us was how to integrate these different data sources and analytical possibilities in a way that GIS analysts will be capable to run the analysis and get the same results without the need of code or or involve any other complex skills. So put together, this is only possible because we used ArcGIS and putting together these solutions and creating this toolbox that will allow any GIS analyst to run the analysis and get the same results without no need of coding was the main challenge for us. And I believe that is the most important advantage of this toolbox, because right now there are few companies running such type of analysis if you ask for, and they are asking for several thousands of dollars to provide you with the same information. So I believe that converting this and trying to create this strategy to leverage the possibilities of use this information and to offer this toolbox to the GIS community was the main challenge, but also the most important one.
Yeah, it's interesting. I think about what you did, and you really had to put yourself in the shoes of your users and what was going to work for them and what would be available on the tools that they might have at their disposal. And then you had to think of that for all the different places around the world, so that really was as universal as possible. Big challenge, well done. Juan, how about for you? What do you think was the hardest thing? You made it all look kind of easy.
Yeah, so bear in mind, summarizing all what we have done, what we're still doing, is a digital express transformation of the public health system. Now, digital express transformation because of the pandemic. here you're always going to have a time constraint. Nonetheless, that's not the hardest thing that we faced. The hardest thing that we faced was that because we were working, remember, we are a Central American country, even though we do have a couple of electronic health registry systems deployed nationwide, a lot of our health professionals, they still believe in hard paper. So the hardest thing was to make the switch from all of our professionals working the paper and into coming into the 21st century and working with a personal digital device such as this one, where you can really quickly digitize all of the information that you're gathering normally, so that we can then perform all that big data analysis and all that, perform all that analytics and give the decision makers the information in a quick and in a really effective, time-effective way. I believe that that was the hardest part, just getting in the midst of a pandemic to all the different health professionals and just transform the way that they were working. And I believe that that was the hardest thing and the most beautiful part of all this project also.
Well, it occurs to me that, you mentioned that you did this digital transformation across the country in 45 days. And I'm taking notes, right, as you're talking, and I just put, wow, because that's huge. But it hadn't occurred to me until you said it, that change management had to be hard. And I just wonder if the speed with which you did the digital transformation was kind of like the ripping the Band-Aid off, and it really maybe in some ways helped the paper lovers to see value faster and maybe embrace the change. I don't know. What do you think about that? What was the key thing to make them see the light or see the ones and zeros?
So first and foremost, I have a wonderful works. So
You're coming in and out a little bit. This was the story of my life yesterday with some internet failures, and hopefully. Okay, there you are. Now you can start your answer over.
Yeah, okay, cool. Sorry. So yeah, first and foremost, we have an amazing team that helped us throughout this digital transformation, and it's currently helping us with the vaccination effort. What we did was that we created a training system in which we train trainers, we train champions in each one of the different health regions, in each one of the main hospitals nationwide. And we showed them that instead of taking between 7 to 11 minutes to write with hand each one of the data that they had to gather from the patients, we cut that time all the way to 2.5 minutes, because Panama has a national ID and all of our information is encrypted. So you basically just have to read it, and then you already have half of the job done. All the other things that you gather are either gathered through the chatbot to Rosa, or through the medical contact center, or on site. So what we did was that we showed them that by using technology, their efficiency was 10 times higher, and that they could go and visit 20 houses in one workday, or 40 instead of 2 or 4 in half a day, just because we knew where they were, we knew where the houses were located, and we knew which was the fastest route. And we also prioritized several cases based on how really complicated the medical case was for the patient. So this sort of insight helped them, let's say, do that leap forward into adopting technology and leaving that paper outside. But believe me, it cost us a lot. I mean, I think that we all bleeded, we all cried, we all sweated in those 45 days. So it was, but nonetheless, it was a beautiful experience.
It makes for an inspirational story for those who are thinking about their own organizational digital transformations. Knowing what's possible, I think, is particularly inspiring. I wanted to go back to this idea, Jisoo, of surveillance and surveillance data and the work that you did and everything that you put together. And I was just sort of thinking about, especially from the Pan American Health Organization, there is probably a certain regional expectation for systemic response and information and what you're able to provide to your region. And so I'm just thinking about the future, and has your experience with COVID done anything that is going to build that system that everybody will expect for the next event? Are you moving the technology forward in ways that are helpful to your organization and your region?
You know, I think that's a really great point, that this COVID, the pandemic is really special. It's not like anything I've worked with, certainly in my lifetime. And it's a global response. It's a global call for ministries of health to really share their information and share their data. And then it's the responsibility of the WHO to take that information and act on it and identify problems and really understand what is happening at the global scale, not just at the country scale. So there's certainly this responsibility that the WHO has to, to take the information. And I think this huge willingness for the governments, for ministries to share their information so publicly, so openly, is not something we've seen in previous epidemics, previous outbreaks. And I think this hopefully will stick, and this willingness to share and be open with the information will be something that we work on. Now, I think the problem then is going to be, how do we transfer the data, and how do we get that information? How do we standardize the format? And I think that's something that we're going to have to continue to solve as we go on.
Thank you. Yes, we've certainly scratched the surface, and I think in many ways, the pandemic and other emergencies in similar ways really magnify those areas where we have opportunities to improve. Sometimes those magnifications are painful, but they're often useful, and they really drive our technologies and our processes and policies forward. So I'm thinking, Juan, about all of the blood, sweat, and tears. It's often painful, but it gets us somewhere important. And so I was thinking about you, Thiago, and I mean, the amount of data that you had to crunch to be able to come up with, for example, the population estimates. I mean, that's some difficult, heavy computing. And I was wondering, I mean, on both sides, the facilities and the population, any of the data that you had, if there was one data set that you wish was available universally around the world, what would be the most useful data set that we should all start working on making available?
I believe that a master list from health facilities covering several countries will help a lot, several efforts in terms of vaccination campaign design, micro planning, and access health systems discussion. So I believe that there are some efforts being performed right now. So this Health Sites IO that I mentioned was one of the initiatives that are trying to get this countrywide master list of health facilities. But this is a huge challenge because you have different levels of information available in the country. So create a platform so you can gather this information and trying to make it comfortable, considering the different data sources in the different countries, will help to get this information together. So I believe that this is the main data set that can leverage the possibilities in terms of how to design strategies to tackle COVID-19, but not just COVID-19, like other disease, polio, measles. And I believe that it is one of the data sets that will be awesome to have this information available worldwide.
I can hear colleagues just in my head clapping and cheering that that's a great answer. I know it's much sought after data set and folks are working on that. So I personally agree with what you're saying. There is an audience question and it came in, Jisoo, while you were talking, but I'll invite anybody to answer, but I'll invite you first. This person asked, what was the process like to standardize data visualization practices across different nations with different data sources? So I know several of you could talk to that. And was there a final arbitrator for how the data was displayed?
So that's a good question. What we did was to take all the data available and we standardized it to our format. So we selected the minimum number of variables, which ended up being coronavirus cases, deaths, and recovered. We're now working on active cases actually. And so we're taking the number of cases and basically trying to figure out how many how many of these variables were there that day. And we standardized it to our format. We saved it into our SQL database servers, and we use that information for our visualization. Now, I think that means that we didn't have data formats that were just raw into our visualization. So I think it made things a little bit easier to visualize at the end, but it really made things a lot harder to collect in the beginning, if that makes sense.
Yep, absolutely. Does anybody else want to weigh in on that one? I think it was most appropriate for you, Jisoo. I guess I want to ask my last question for everybody before I say a few words and we wrap in this session. But my last question is really about the future. One of the fears, I almost panic sometimes thinking about it, is that, maybe as the pandemic winds down and people can relax a little bit from all of this work that everybody's been focused on for so long, that we'll forget the lessons we've learned, or we'll lose momentum toward digital transformation. Panama doesn't have to worry, they've already finished it. It took 45 days. It's amazing. So, but do you think we're going to remember these lessons? Do you think that GIS is an important part of the future of not only pandemic response, but public health preparedness in general? So let me start with you, Thiago.
I believe that all the efforts and all the technology developed to tackle COVID-19 will remain, so it will be available to support other initiatives and other challenges. And I'm pretty sure that all the lessons learned during this pandemic will be available in the future. And I'm pretty sure that GIS will be leading such type of efforts and the availability of technologies and tools and strategies to overcome, because in the health domain, location matters. And for each problem in which location matters, you need to use a GIS approach to support decision-making process. So I'm pretty sure that all this technology will remain, will be available. And the pandemic pressure is contributing to develop and to pay attention to what is needed in terms of strategies to tackle the COVID-19. And this effort will be available for the next years, I'm pretty sure.
Thank you. So from your perspective, I don't have to panic. Juan, what do you think? Are those lessons learned sustainable? Will we keep moving forward?
I was just remembering, we're in 2021, and I think that looking back into what was the early 2010s, when we were talking about cloud, and then we were talking about machine learning back a couple of years ago. And I think that all of this talks that we've been having in the tech industry, they are close to none into what COVID-19 has been as a digital transformation engine for the world. 2020 was a year when we started working from our home place, from our home, and we stopped going to the office. I believe that there are lots of lessons that we have learned into quickly how to adapt to the times. I do believe that GIS is a big winner from this pandemic. There are tens or even hundreds of national dashboards, just as Jisoo Kim showed us earlier. Every nation has had a sort of GIS dashboard showing how the disease is going. I remember early in February 2020, we were looking amazed how the pandemic was evolving in Italy. Italy had a great GIS dashboard and that's how we saw a country going for the first time top of the 80,000 cases, and everybody was like, whoa, what's going on there? I hope that this doesn't get here. 3 weeks later, it was our turn. So yeah, I do believe that there's a lot of lessons learned. I believe that the systems, the health systems nationwide, worldwide, I'm sorry, are beginning to understand how it is that they need to have a symbiosis with this sort of technology, not just for COVID. In the Americas, we have a lot of other diseases such as dengue and chikungunya that kills hundreds of people every year. And I believe that we are going to be looking more use of GIS tools just to trace how they are, how these pandemics are, these different outbreaks are ongoing. So yeah, I believe that there's a bright future.
So Jisoo, last word, hopeful or not hopeful?
Definitely hopeful. I couldn't have said it any better than Thiago and Juan has shared with you. So I think the fact that we have these kind of efforts at the country level really makes work at the regional level and the global level a lot easier. So there's just technology available for cheap, for free everywhere, and it really gives so much opportunities for GIS to flourish in the surveillance systems of our countries.
Thank you so much. Thank you to everybody, Thiago, Juan, Jisoo. Your stories are so inspiring. The work that you've done, you've showed that there are challenges, they can be overcome, and you can get to amazing results that really support all of the missions that we've been trying to solve for during the pandemic. So thank you to the organizers for the honor of hosting this panel of experts. I hope that the viewers are inspired. GIS is obviously helpful in these kinds of efforts, and we just heard it's going to be helpful in the future. So thank you very much.